You know that feeling, right? You're all set to leave the hospital, doctor says you're good to go, but then you're just stuck,
Well,
waiting, waiting for meds, waiting for paperwork. It feels like it takes forever. Or maybe you've seen it from the other side, a packed ER, and you're wondering, why aren't there any beds?
It's incredibly frustrating, and it's not just an inconvenience, is it?
No, not at all. It's a real system issue.
Yeah.
It impacts patients. Their families are obviously stressed. And like you said, it really does jam up the emergency departments. Feels like this impossible problem sometimes.
It can feel that way, absolutely. That sense of helplessness, it's felt by everyone involved. But today we're doing a deep dive into how one, really prominent cancer center decided, nope, we're not just accepting this.
Oh.
They tackled it head on. And they used some pretty powerful tools, things you might not immediately think of for healthcare, maybe more for like industrial efficiency.
Right.
So our mission today is really to pull out the key insights from what they did, see how looking really closely at the process can totally change patient flow.
And what I find really interesting is the King Hussein Cancer Center, KHCC, over in Amman, Jordan. They didn't just tinker around the edges, did they?
No, not at all.
It sounds like they really engineered a blend of these powerful data-heavy methods, bringing industrial engineering thinking right into patient care.
Exactly. And our source for this is a great research article from the Journal of Healthcare Engineering detailing exactly how they did it.
And it wasn't about, building more rooms or just hiring tons more people. It was about working smarter with what they had. Okay, let's dig into this. So patient discharge, it feels like the last step, checking out, but you're saying it's way more central than that.
Oh, absolutely. It's like a crucial gear in the whole hospital machine. What happens, or doesn't happen efficiently, at discharge creates ripples everywhere else.
Okay, explain that ripple effect.
Well, think about it. If discharges take hours longer than they should, those beds stay occupied. That directly reduces the number of available beds throughout the hospital.
Right, which then backs up into the emergency department.
Precisely. It's a major, major cause of ED overcrowding in, tons of healthcare systems. If there's no inpatient bed ready, that ED patient waits.
And that waiting isn't just annoying, it can be dangerous.
It really can. It leads to delays in getting diagnosed, starting treatment. It lowers the quality of care, and sometimes, sadly, it leads to worse patient outcomes. It's a truly systemic problem, not just an isolated delay.
Really is. And, the typical response might be, okay, we need a bigger building or hire more nurses.
Yeah, the default is often expansion.
But this KHCC study points another way, right? Focusing on the process itself, that sounds like it could offer a much better return on investment.
Absolutely. You're optimizing the resources you already have, making them flow better, instead of just adding more layers onto a potentially inefficient system.
So they're facing this big tangled knot of discharge delays. Where do they even start? What tools did they bring in? I'm guessing some quality management techniques?
Yeah. They definitely did. They leaned heavily on Six Sigma. Specifically, they used its DMAIC framework, define, measure, analyze, improve, control.
DMAIC. Okay, familiar territory for quality improvement, folks.
Exactly. And they applied that really rigorous, data-focused discipline, which, started at Motorola, got big at GE for manufacturing. They applied it to this very human, sometimes chaotic process of getting patients home.
It's kind of amazing how adaptable it is. We've seen it used for reducing medication errors, speeding up lab results.
Right. Its structured scientific approach is key. And they didn't stop there. They combined it with another really smart tool, Discrete Event Simulation, or DES.
DES. Okay, break that down a bit. It's more than just software, right?
Oh, yeah, much more. Think of it like building a virtual dynamic copy of your real-world system. In this case, the whole discharge process, step by step.
Like a digital twin of the hospital floor.
Pretty much. It becomes this sort of virtual sandbox. You can try out different changes, big changes, small tweaks, see what happens, without actually messing with real patients or staff schedules.
That sounds incredibly useful. You can test what-ifs without the risk.
Exactly that. DES is a powerful decision support tool. It lets hospitals really grasp the complex, dynamic nature of their processes and, crucially, predict the results of changes before they spend time and money implementing them. It came out of industrial engineering back in the 60s, but it's really finding its place in healthcare now for things like patient flow, bed management, staffing.
Okay, so Six Sigma for the structure and the data discipline, DES for the dynamic modeling and testing. Did they just use them side by side, or was there more to it?
And this is where I think it gets really insightful. They didn't just use them in parallel. They integrated them. They used the DMAIC framework to guide the whole project, but they used DES powerfully within that, especially in the improved phase. And crucially, they added another layer: detailed stakeholder analysis.
Stakeholder analysis, so understanding the people involved.
Exactly, because processes don't exist in a vacuum. It's this blend, the data, the simulation, and the human element that really made the difference. It's holistic.
Okay, let's paint the picture at KHCC. It's a specialized cancer center, 262 beds. You mentioned they discharged nearly 9,000 patients back in 2016. So, a busy place.
Definitely, a significant volume. So step one, the define phase in DMAIC. The team had to be really clear about what they were tackling.
Scoping it out, right.
Right. They focused specifically on medical patients, leaving out surgical patients who often have more planned, predictable discharges. And they defined the process precisely, starting when the doctor signs the order, ending when the patient leaves the room. Clear start, clear end. That's vital.
Makes sense. You need boundaries.
Yeah.
So after defining it, they had to measure it. How did they get the real data?
This part is fascinating. They didn't just pull records. They got really granular. They actually shattered 38 patients and their families.
Wow. Literally followed them through the process.
Yes, seeing it through their eyes. They timed every single step, every wait, every interaction. Real-time, ground-level data collection.
That must have been eye-opening. What did they find initially?
It confirmed the problem was real. The average discharge time. A whopping 215 minutes.
Wow. Almost 4 hours?
Right. After you've been told you can go home. Just imagine. And the data also showed something else interesting. There were really two types of discharges happening.
Nice.
Standard discharges, pretty routine. But then complex discharges for patients needing extra things, special equipment, certain supplies, maybe last-minute medication changes. Those took significantly longer.
And they put a number on the efficiency too, right? The sigma level.
They did. They calculated the sigma quality level, the sequel, and it was only 0.72, which in Six Sigma terms is, well, it shows there's a lot of room for improvement, huge inefficiencies.
So defined and measured.
Yeah.
Problem is clear. It takes way too long. Now the analyze phase. Time to figure out why.
Exactly. Detective time. They use tools like cause and effect diagrams, fishbone diagrams.
Ishikawa diagrams.
Right. And lots of brainstorming with the staff involved to really drill down into the root causes behind that 215-minute average.
What were the main culprits they found?
Several big things emerged. One was just fragmented and unstandardized processes. Orders for discharge, for meds, for supplies, they weren't happening in a consistent sequence or time frame. Sort of ad hoc.
Okay. Lack of standard work.
Definitely. Another was a lack of pre-planning. Thinking about discharge needs often happened way too late in the stay, but a huge one was poor communication.
Communication breakdowns. Always a factor.
A massive one here. The study even included a communication complexity diagram showing all the potential points of failure. Doctors, nurses, pharmacy, even accounting, not always coordinating smoothly.
Can you give examples?
Sure. Delays getting radiotherapy or chemo scheduled, holdups with diagnostic tests or imaging results needed for discharge, even things like hospital security processes or families disputing charges for companions staying overnight claiming they were just visitors. All these little things added up.
And the physical layout, too.
Yeah, that played a part. The distance between, say, the pharmacy and the accounting office physically added travel time and delay.
It's incredible how all those seemingly small friction points just stack up, isn't it?
Mm-hmm.
Compounding into that massive 215-minute wait time.
Exactly. No single huge blockage, but lots of smaller delays creating a major bottleneck overall.
Okay, so this leads us to the improve phase. They know the problems, they know the causes. How did they use that simulation, the DES, to find solutions?
This is where the DES really came into its own. They built that digital twin using ProModel software, modeling the entire discharge flow as it currently was.
The baseline model.
Right. And first, they had to make sure the model was accurate. They did a verification, basically watching the simulated patients flow through to make sure it looked right, and validation comparing the simulation's average time to the real-world time.
How close did they get?
Amazingly close. The simulation averaged 213.38 minutes, while the real average was 215.7, an error of just over 1%. That gave them huge confidence that the model was a reliable replica.
Okay, so they have this trustworthy virtual hospital. Now they can start experimenting.
Exactly. They tested various potential solutions within the simulation to see the impact, and they found some real winners.
Like what? What worked?
Well, one big one was creating a dedicated discharge fast track within the pharmacy. That alone cut the average medication prep time from 88 minutes down to 30.
Wow, nearly an hour saved just there.
Yeah, translating to about 36 minutes off the total discharge time. Another idea. Have the clinical pharmacist actually transport the meds to the floor.
Instead of waiting for a porter or tying up a nurse.
Right. That simple change saved another 21 minutes in the simulation by eliminating waits and calls. Even just ensuring more than one porter was available during peak times saved over 8 minutes on average.
These are smart, targeted changes, not necessarily huge investments.
Exactly. Announcing the need for special equipment a day earlier saved over 4 minutes. Bringing supplies to the patient floor instead of making families trek down to the outpatient clinic saved another 7 minutes or so.
It's the power of accumulation, isn't it? Lots of focused improvements adding up.
Precisely. And when they ran the simulation, with all these proposed improvements applied together, the result was pretty dramatic.
What was the final number?
The average discharge time dropped from around 216 minutes down to just 98 minutes.
No way. That's a reduction of about 54%.
54%. Just incredible. And it wasn't just faster, the process became much more reliable. The Sigma quality level jumped from that dismal 0.72 up to 2.67.
Meaning far fewer patients experiencing those really long waits.
Exactly. A massive improvement in both the average time and the consistency. Huge win for patients and for hospital flow.
Okay, define, measure, analyze, improve. Amazing results. But then comes the control phase, making it stick. That's often the hardest part, right?
Arguably, yes. Implementing changes is one thing. Sustaining them, especially in a complex environment like a hospital, is another challenge entirely. You have to anticipate resistance.
And you mentioned healthcare has unique challenges here.
It does, and a big one is physician autonomy. Doctors are highly trained, independent professionals. They can be, quite understandably, resistant to standardization if they don't see a clear benefit for their patients.
So you can't just issue a memo saying, do it this way now.
Not effectively, no. Quality improvement in healthcare often requires more nuance, more engagement than in some other industries. You need buy-in.
Which brings us back to that stakeholder analysis you mentioned earlier. That sounds critical for the control phase.
Absolutely crucial. They didn't just identify who the stakeholders were, they mapped their level of influence and their level of interest in the changes.
So you tailor your approach based on that.
Exactly. For instance, physicians, high influence, but maybe low initial interest in process change itself, the strategy. Get them involved directly in designing the solutions through workshops, meetings. Build that ownership.
Okay, makes sense. What about other groups?
Groups like pharmacy, accounting, medical records often had medium impact, but maybe lower intra in leading the change. For them, things like implementing a new electronic discharge system were proposed tools to make the new process easier and more standard.
And the families.
Patient families, identified as having high interest but low direct influence on the process itself. So the plan was for a dedicated discharge coordinator to engage them individually, explain the process, manage expectations, handle special needs. Personal touch.
And you mentioned RACI matrix. How does that help control things?
The ASCI, responsible, accountable, consulted, informed. It's about assigning crystal clear roles for each step in the new process. Who does the task? Who owns it? Who needs to be asked? Who just needs to be told?
So it cuts down on confusion and people stepping on toes or dropping the ball.
Precisely. It clarifies expectations, improves communication, reduces wasted effort. It's a key tool for making new processes stick.
And they track the results afterwards.
Oh, yes. The study showed control charts, visual graphs tracking the discharge time before and after the changes. They clearly demonstrated not just the lower average time, but also a much more stable, predictable process over time. That visual proof is powerful for keeping everyone on board.
What an incredible story from KHCC, taking this really complex, frustrating process and using these, well, almost industrial engineering tools to cut discharge time by more than half, from almost 4 hours down to about an hour and a half. So thinking about this whole deep dive, what's the big takeaway for you?
For you listening, I think this KHCC case is just such a powerful example. It shows how structured methods like Six Sigma, when you combine them smartly with tools like simulation, and critically when you pay close attention to the human side with things like stakeholder engagement, you can solve really tough operational problems, even in fields like healthcare that seem inherently complex and resistant to standardization. It's about seeing the whole system, how the pieces connect, and then making smart data-informed changes. It leads to better outcomes and, honestly, more humane experiences.
Absolutely. So here's a final thought for you to chew on this week. Think about some process in your own life. Could be at work, could be at home, maybe just part of your daily routine that feels clunky. inefficient,
Hmm.
needlessly long or complicated.
Mm-hmm.
How could applying that kind of define, measure, analyze, improve, control thinking help? What if you thought about the stakeholders involved, even if it's just you and your family? Could you find a surprising shortcut? Could you identify those non-value added steps and just eliminate them?
Yeah.
Start observing,
Yeah.
start asking why, and who knows, you might just uncover your own 54% improvement somewhere unexpected.